Welcome to the Talking Turning 65 live stream, where you look forward to being 65, or you wish you were still 65 and want to make the right decisions for your retirement years. Grab a pencil and notepad and join us to find out ideas to build security in your healthcare, wealth care, and estate care. And now is a good time to tell a friend we are live. And now, here is your host, Mark Rogers.
Welcome. Good to see everybody. I hope you invited a friend, because we're going to share some interesting stuff, but I do want to bring good friend Leith on. Leith, thanks for coming on.
Nice to see you.
Hitching up to this train of crazy Medicare broadcasting, huh? And of course, you take a special unique perspective to it because you do Medicare, but you've been helping folks for 20 years, as I have as well, and we really enjoy helping people. So it's a real privilege to be able to come on every Monday and share these things.
Yes, thank you.
Yeah, so let's get on it. And I want to invite on Rhonda. Rhonda is out of the Midwest in Iowa, particularly. Hi, Rhonda.
Hey, how are you doing?
Good to see you. I'm so glad. I've always enjoyed doing these with you, and thanks for coming on for the Medicare side, because normally we're doing a long-term care session together, which we will continue to do those, but today, as we know, it's early October, and all the retirees right now are sitting here trying to understand what they're going to be doing for next year. So thanks for coming on for a few minutes. And be thinking about a good story, because there's people that are searching for help right now, and maybe there's someone that may have a good story on what you're dealing with, because not everybody's all that different from each other. We're all dealing with some of the similar challenges we have in retirement.
Yeah.
All righty, let's get right into it here and tee up everybody needs to go over to Medicare.gov. Just an FYI, we're going to talk about Medicare.gov in just a second. But we wanted to talk about this news. This is a Market Watch piece that just came out here on October 3rd, and it's talking about Medicare users could soon lose perks they love, like choosing their own doctor. There will be denials of care. And now this is not what retirees want to hear, but it's a pretty interesting thing here. So I'm going to read a piece of it here out of Market Watch. One of the benefits of traditional Medicare is the flexibility of choosing your doctor and the ease of seeing specialists, but that is about to change. Healthcare providers under Medicare could soon be tightening their spending by scaling back care or requiring more prior authorizations, like the Centers for Medicare and Medicaid Services pushes to have all those beneficiaries in cost-cutting models by 2030. So the CMS is publishing this new strategic goal to move Medicare and Medicaid beneficiaries to accountable care arrangement with providers who assume the financial risk of providing care. So let's see what this means. Under these arrangements, groups of doctors, hospitals, and other healthcare providers work together to coordinate patient care. The accountable care organizations then are financially responsible for the care provided, getting bonuses if spending is lower than targeted, and penalties if spending is higher. Get a hold of it, folks. Keep on reading here. Accountable care organizations, that's a particular term. Accountable care organizations are structured to operate more like Medicare Advantage plans. They're rewarded for not providing care. There's more prior authorizations, said Mary Johnson, an independent Social Security and Medicare analyst. It's a way for the government to save more on Medicare. There will be more denials of care. We're going to highlight this here. More denials of care, more delays of care. In reality, patients may not realize they are in accountable care organization, but they may see differences in the care they receive, Johnson noted. Patients are not necessarily going to see the best type of care. People will have the briefest interactions with doctors. Instead of a 30-minute appointment, You may have a 15-minute appointment. Instead of a follow-up with a nurse, you'll get a robot call, a robocall. Accountable care organizations date back to concepts of coordinated care and cost controls in the 1990s. This is a good direction. Matthew Fiedler, he's a senior fellow in economic studies. He's saying at the Center of Healthcare Policy of the Brookings Institution, a non-bipartisan think tank. This is a good direction for a Medicare program to be moving. It could modestly reduce spending without hurting care. All right, Rhonda, I'm tossing it over to you. And Leith, you're in that. You're going to be faced with it as well.
Oh, my
man, I
goodness.
have so many things running through my head. First thing I come to mind is a couple of years ago, I was working employer benefits for Drake University, who provided for the retirees, because we know it's really expensive for the retirees to keep them on program. So they switched over to their own group Medicare Advantage plan. What we were finding, and this is no surprise, is a lot of the physicians were dropping out of that specific company carrier's network. So now these people are being pushed to have to find a different provider. And they had asked me to come in and see if I could help them out with that. And I'm like, actually, it was a good thing, because the group Medicare Advantage plan is actually costing them something every month, where in our area, we could get them an individual Medicare Advantage plan for a $0 premium. But fast forward 3 years, we continue to find providers saying, we don't want to play the Medicare Advantage space. We don't want to work in managed care. We want to do the procedures, order the labs. We want to do what we want to do. We don't want to be told what we can and cannot do. So I think that you're to this point is people specifically with the Advantage plans are going to continue to find struggles with providers in those networks, in those zip codes or regions that they're in.
Leith, this actually ties in to something else to share. It's going to be really closely tied to it. Let me pull it up here. Leith,
I just want to say too, Mark.
Yeah, go ahead.
I just want to jump in here. When you were reading that, I was thinking back to the 1990s when I was in human resources and benefits for a large employer. And the same thing happened there. In the early 90s, everybody wanted the HMO because, they were going to save so much money. And if you had a primary care doctor, and the HMO would direct your care. And it really didn't. And then it bounced back to PPOs, and HMOs weren't really doing the job they thought it was going to do. And now here we are again. We're going back to these managed care programs. I don't know if it just comes and goes, and new people that haven't dealt with HMOs before, now they think, let's do an HMO because we're going to save so much money. But I just find it interesting.
So Leith, would you say though, it happened in the employer side of things, in the employer arena, but now it's moving more into.
It happened in the individual market too. I mean,
right.
There were
so the employer and the individual market, but this dilemma we're faced with, or this is moving up into the retiree class, the Medicare class.
Right.
To Leith's point, I remember in the 90s, we called them, particularly on the West Coast, we called them the senior HMO plans. And they, to her point, they weren't working so well, and they all went away. And then fast forward in about 2003, 4, 5, they decided, let's bring back these Medicare Advantage plans. And the other part of that article is saying we are in a nation struggle with finances, right? We have a lot of people that are living longer, that are using Medicare, and we did not plan to accumulate enough dollars. And then we have a medical system that just wants to keep not really getting people better. We want to keep them bringing it back as repeat customers. So we're fighting against the providers, with the insurance companies, and they're all passing blame on each other. But now we're looking at how are we going to manage this care? And by going to this robot calling, or obviously you're not getting one-on-one interaction. So of course they're going to save money because the robot doesn't know to ask up the follow-up questions.
And that really brings in, I wanted to bring this thought. It's noodling around in my mind. If we've got adult kids that are watching our program here, it would really behoove you to start to work with your parents on their health care, because things are going to become more and more electronic, All three of us here on the screen, we deal with insurance companies, and more stuff is going electronic. But now we're talking about healthcare being more and more robot calls. And I would just say, if I was an adult child, or I am an adult child, is to take more interest in parents' care, because we're moving into an age where they're not familiar with the electronic stuff. And this is for another program, Rhonda and Leith, is we're going to talk about these calls that are coming into retirees. That is absolute fraud. So there's that out there too. That's a whole nother mess.
And to tag on what you said, Mark, about adult children looking after their adult parents, obviously, I think that the other problem is that I've seen with some of the retirees I work with, they don't have adult children, and they don't have anyone to help them manage that. Or their children live clear across the other side of the United States. They're a long distance away. So it's really hard for them to be involved and help their family members manage their care. Because it's not like it used to be when you end up in the hospital and your family doctor would come see you and he would manage that. You're talking to a computer. Honestly, I had a friend that was in the hospital and in the emergency room, and she talked to the doctor on a computer screen. Okay. So everything has changed so rapidly that people really need an advocate to help them through that process.
Let's move on.
I was thinking the same thing. You have to have an advocate. I even remember when my dad was in the hospital and I said, "What's going on here?" He's picking stuff out, recalling things out the window. And they're like, "We'll bring in a psych consult." I'm like, "A psych consult? Didn't you increase his pain medication? Take it back down to the normal strength." And sure enough, he's okay. Now, luckily, I was there. But if you're doing an AI robocall, again, they're not going to read in between the lines. They're just programmed for black and white.
Yeah. Yeah.
It's going to be interesting. All right, let's dovetail nicely into a pilot program that's on the same side of things here, called the Wasteful and Inappropriate Service Reduction. This is a model. And so folks, listen up. If you are in one of these states, New Jersey, Ohio, Oklahoma, Texas, Arizona, or Washington, by the way, we're getting this is off of the CMS website, cms.gov. There is going to be, as has already been said and alluded to, this wasteful and inappropriate service reduction model will help protect American taxpayers by leveraging enhanced technologies such as artificial intelligence and machine learning, along with human clinical review, to ensure timely and appropriate Medicare payment to select services and items and services. This is a test program in several states. The reason why they're bringing this up, and this is going to impact probably your healthcare in one of these states possibly, is that waste in healthcare can not only harm patients, but also contributes up to 25% of healthcare spending in the United States. Wasteful, low-value services, often limited clinical evidence of effectiveness, may not align with an individual's specific health condition or needs, or can lead to complications and further unneeded services. So this is called the WISER model. WISER, W-I-S-E-R model, will help reduce clinically unsupported care by working with companies experienced in using enhanced technologies to expedite and improve the review process for a pre-select set of services. That's about all I have on that.
I think that it's a large document. I was in cms.gov, and it's a large document that talks about this new program that they're putting out there. It's a pilot program, and it talks about using AI services to decide whether people needs a service or not. They've narrowed it down to, I think, 4 or 5 different diagnoses. So I don't think we really need to go into there. If somebody wants to look, they can go and look it up at cms.gov. But it's, again, it just dovetails on what we're talking about. Who's going to manage this? Who's going to make sure it's being done the right way?
Any thoughts on that, Rhonda?
No, and to me, in the end of the day, they're just looking at ways that we can cut. They're looking at cutting labor, hours to review these charts. They're not, how are we going to not pay? How can we save dollars for actual care? I do agree that there's a lot of waste there, because these doctors having you come back all the time for what? For 15 minutes? I chuckled earlier when you said, oh, we're going to reduce a 30-minute appointment to 50 minutes. How many people actually get 30 minutes with their provider? You might get billed for 30 minutes, but you're not there with them 30 minutes. So I'm like, whatever.
Yeah.
Yeah.
I've been using AI more and more in my business. And maybe you are, Rhonda, and Leith is finding out how cool it is. It's absolutely splendid when it works. But the question is still to put eyes on it and say, is this really true or not true? That's
Right.
the key thing. And when you're dealing with someone's health care, going back to what we were saying, you got to have an advocate. You have to have another family member really questioning stuff. Yes, there's going to be cost cutting. Yes, there's waste and fraud. I get it. But is the AI really going to do it is when it comes to your care. So,
And I think there is waste and fraud, but I think the majority of people get good care. But when you start throwing restrictions in where AI is going to decide whether your authorization is going to go through, who would have ever, I would never would have thought this would be happening. You're going to use an AI tool to decide whether I get a knee surgery or not.
yeah.
That's crazy.
Yeah.
So it's the
Oh,
world we
good.
live in.
All right. We're going to have one more. We want to bring one more in here, new for 2026. Leith wanted to bring this to the table. Folks, grab your Medicare and U-Book and jump on down to page 31 at the bottom. I'm going to share with what this is going about. We're going to talk one new thing for 2026, bottom of page 31. And basically it says that Medicare now pays for advanced primary care management services each month, where your doctor and your other healthcare provider coordinators and tailors care to your needs. Providers that offer these services must give you 24/7. I'm going to move Leith out of the way here. 24/7 access to your care team or provider or more. Again, we look on the bottom of page 31, and you can see it way down at the bottom, this advanced primary care management services. Leith, take it away. What does this mean for retirees in 2026?
I think this is a great addition, and I hope it works well for everyone because it's just what we were talking about. Who manages that care for people?
Right.
If somebody has a serious health condition, if you've got an elderly patient who doesn't have any family members or their children or caregivers are out of state, then this is going to pay for the coordination between physicians to manage that care.
Got it.
It's pretty simple. Whereas
Good.
before, one doctor would do this and another doctor would do that, and somebody else would do that. Now they don't say how it's going to be, how much it's going to cost or anything like that, but it's there.
Got it.
There for get reimbursement to have this care coordinated, and I think that's a great addition.
Any thoughts on that, Rhonda?
Oh, my glass is not quite as half full as Leaf's is. Yes, I think it is smart to have the managed care because you have multiple. And if you think about it, you go into your doctor and they want to refer you within the organization. So you do have multiple physicians coming in and they are supposed to be coordinating together. But how often does it actually happen? Because they're all so busy seeing patients all day. Can they actually focus on it? I'm a little bit worried about the fact that they're going to manage it, having that coordinator to manage it. Just like when you leave a hospital, supposedly all these doctors are supposed to be coordinating together while you're in the hospital stay, and that doesn't always work out either. But I do think it's another way for them to say, instead of bringing dollars in for the cardiologist, the neurologist, the primary care physician, can we save some dollars by managing it together so we're not maybe running to all these outpatient appointments? And maybe that's part of their objective. I don't know.
Got it.
When I read it, now I took it to mean there's going to be a team of people, or there's going to be, because it says providers that offer these services must give you 24/7 access. So the provider has to, number one, offer the services the way it reads, and then they access a care team. I think it would be really helpful for those people that are really in acute distress and have some really serious diagnoses, but luckily they're paying for it. So we'll see how it works out. But it appears that the doctor has to decide to use these services. So
I like the
Well,
fact that they can call a 24/7 number hotline and access their team that can have
right,
access to the whole system. That I'm
right.
100% behind because
Yes,
I do think the telemedicine has been a wonderful thing. And
I
I
do
kind
too.
of see if that's a 24/7 access to their care team management, I think that
Hmm.
is a good thing.
Yeah.
What what do you see, Rhonda, while we're out? What are you seeing for 2026? What do you see in your neck of the woods? You're in the central U.S. What challenges are you seeing as you look at as we're now at the top of October? We're looking at a busy season. I just been hearing that this is going to be a crazy Medicare season. So, what's your
Yeah. Well,
feelings as we move forward?
going to all the carrier meetings, we're seeing the Advantage plans are going to be really on the chopping block.
I
that's
see.
that's what we're going to see a lot of changes going on this year. I wonder. I think there's a lot of things that's contributing to it. One one of the resounding messages from one of the carriers is, "Wow, we took on a lot of Medicare Advantage more than we thought. We don't want to grow that business anymore. We just want to grow the Medicare supplement business." So
That's right.
basically, they're saying we'll continue servicing the people we have, but either they're just not offering the PPO products, they're only pushing them to the HMO, which is going back to this whole managed care, or some of them are just saying, we got a lot of counties in our big rural parts of the state of Iowa that are just simply saying we don't have providers. We're dropping those plans. So we're going to see them only in the metro areas. And then the other thing that we're seeing is they're saying, hey, we don't want to pay agents. One way you get an agent not to write a product is don't pay them.
Okay.
That's what they're going to do too. But in all, we're going to see that. I think we're going to see cuts to those friendly benefits, the hearing aid, the dental, the vision benefits. I think we're going to see more cuts with that. And then along with part of the changes is because of the prescription drug plan, they put the cap for the 2,100 on prescriptions this year. And so these companies are having to pay more out, which is the whole objective is we want the insurance companies to pay some, we want the Medicare to chip in some, and we want the pharmaceutical companies to chip in. The first thing the insurance companies said is we got to pay more on the back end. We're going to reduce what we're going to pay. So
And so there's a lot of changes that people, and so one of the things that rings with me, Ron, is probably with you as well, is there's a lot of people that are sitting there dialing the 800 number on the TV, trying to get consultation. And after being in the business for 20 years, Leith, 20 years, Rhonda, you're what, 20 years plus, right? It's
30, almost 30.
30. Yeah. So we got a lot of experience here on the screen. And what I'm getting at is this: having a relationship with an agent is key. And to be able to have the phone calls, the coffee times, the whatever throughout the year, not just this time of year, but to be able to have that. But it's amazing how many people just decide to dial 1-800 whatever insurance company off the TV, and it's not necessarily the best plan. They're not surely not, to your point, they're not sharing the secret. We found secret plans behind the scenes that we know about. I share we're going to talk about Zoom webinars coming up here that we're going to share some ideas. We don't do it out here in the public, but get behind closed doors. There's some good stuff. There's some ways to build planning that is not necessarily being told to you on the TV advertisements. So there's my little warning for those that don't have the relationships with agents.
And the other thing, Mark, if you call a 1-800 number, they're just there to write you whatever plan they're selling. They're not there to really ask you the important questions, ask the consumer the important questions about what is their plan, what is their income, what are their needs.
Right.
Do they have other plans? There's so many questions to ask when you meet with a client. It's just not call 800 and sign me up. It's just
right. Because one of the things, just to build off of what I was just saying there, is I have something called the House of Healthcare, where we're building care based upon Part A, Medicare Part A, Medicare Part B, Medicare Part D. We got to understand, this is why we're going over the changes along the way. We have to understand how Medicare operates. And then over on the side, we are building I do Med Sups, a Med Sup plan. And then on top of that, and that's to plug in the holes that Part A and Part B may have. They have holes. But then we have on top of it, we need to maybe dental care, that's a whole nother topic, isn't it, Rhonda? Dental care?
Yes. Dental and vision.
And vision. Let's put that in there too. Too many retirees are later on in life and they haven't done adequate dental care along the way. And then we were just on a webinar yesterday, and then you have cancer. And we understand that we heard yesterday that your Medicare doesn't pay for wigs and things like that associated with cancer stuff. And so having a cancer plan and or a hospital indemnity plan, we're going to be talking more about that here as we roll forward, a hospital indemnity plan. And this is where you want to build this house of healthcare and understand how everything works. And if one piece doesn't work, we may pull that off. But at the end of the day, at the bottom of this, Rhonda, you're going to get a kick out of this. This is going to be the custodial care. That's our foundation. Our foundation is our custodial care. And so that's another thing to address at another time, custodial care, because the Medicare stuff here is only going to be, the Medicare stuff is only skilled care, which is a whole thing to understand. In fact, I do want to pitch that right now as this is a piece here that makes things very clear. Skilled care is your Medicare Part A and B. Basics of Part D, that's your drug cards. We're talking about those. Basics of Medigap plans, that's skilled care. Dental care, vision care, hospital gap options, that's all skilled care. But over on the right-hand side, where we have custodial care, that's where you're generally having to come out of pocket for that cost of care at home, cost of care at a facility. Frankly, if you're pulling from your 401k and IRA for this money's, how you like that, Rhonda? The cost of care from the IRS?
Yeah. I heard somebody say the other day, and I thought, wow, that's a really great way to say it. Everybody thinks, oh, I've got so much money in my 401k. Don't brag about it too much, because when you have a 401k, you're in a partnership with the IRS, right? And eventually there's a short-term loan that they're giving it to you tax-free, but they're going to call up their loan and they're going to want it. And if you don't, they're going to start requiring you to take it out. And that is a domino. Once it falls, you cannot get that domino to stand back up again.
Once the IRS dips into it and you're being forced, and I'm going to go back to this, when you're being forced to pay for custodial care from your IRA, your 401k, it's disastrous. Now, we're going to talk about in future times, we're going to talk about options for 55 to 65-year-olds. We'll talk about options for the 66 to 75, even 80-year-olds. There are options that are out there, but I just want to make sure that hopefully my little scribble makes sense, that there is a house of healthcare with different pieces to it. But in order to put that house together, you have to work with somebody that knows what they're doing, and that's independent.
Your house of healthcare, that's awesome, because if you think about it, we need income every month to run our house, right? You got utilities, you got mortgage, you got property taxes, insurance. When you have an extended healthcare event that goes beyond skilled care, because skilled is only rehabilitative. Gee, we're going to give you the treatment that you need to get better. But when you need custodial or assisted extended care that you're not getting better, you need income. And what you're saying there is, if I have to dip into my IRA to create income, you're now paying above the actual price tag to create enough income to pay for that monthly bill. So who wants to pay above the actual price tag for the one place you never thought you'd wanted to receive care, in a nursing facility or a home care?
And what you're saying, Rhonda, just to amplify and put dollars to it, if you need $100 to pay for care at a facility or at home, and you're pulling from your IRA, your 401k, you may have to pull $130 out of that 401k IRA to accommodate the taxes over the IRS first.
Correct. And guess what? Next year, that IRA is not going to produce as much income because you've taken out $130 a day.
Yeah, that's good stuff. Anything else, Rhonda, while we have you on here? Anything else that you want to share with folks? And I want to tell everybody that look down below in the link, you'll see how to get a hold of both Leith and Rhonda. Rhonda, tell me, are you all over the country, or the Midwest, or where are we sitting at?
I'm based out of Des Moines, Iowa. So we are the second insurance capital of the world, right behind Hartford, Connecticut, or out of the United States, I should say.
Yeah.
In Hartford, Connecticut. Hey, Leith, Mark, you guys come visit me. We'll go insurance pub shopping. We won't do the pub crawl. We'll do the insurance crawl. We'll go stop at Wide. We'll stop Wellaby. We'll hit Mark and Equitable. We'll hit them all.
You know,
Sounds good. Sounds good.
Rhonda, when I fly into the Des Moines airport, you walk down the hall, you're seeing all the insurance companies got their billboards in there. So I get it. It's welcome to Des Moines. Yeah. So
Right
your
next
link.
to the soy,
What's that?
right next to the soybeans.
Take the soybeans. Yeah. But your link will be down below. People can contact you there, and Leith's contact will be down below as well. Any good stories to share before we bounce out?
I had an appointment this morning, a couple, they're not even my clients, but somehow somebody gave me my name to help them review their policy. And sad enough, the woman was just really frustrated because we're paying for our Medicare premiums. We're in our late 70s. We're paying our supplement. We got this. We're paying so much money in our insurance. It's taking a lot out of our income. And she was really wanting to justify not keeping this long-term care premium. And she just kept coming back and saying, but if he dies, I'll get his pension, I'll get his life insurance. I said, that's if he dies. I'm
right.
talking about what if he lingers? What if he's still alive? How you just told me you don't have enough income. You're spending 100% of your income. Where's the other income going to go to pay an extra $5,000-$6,000 a month outside of what your insurance, out of your house of healthcare?
That's right.
Yeah.
That's right.
And he just kept saying, well, if he dies, I after 3 times, I cancel it. I don't care. But
yeah,
that's what we're talking about. If you have a bill, where are you going to get the income to pay for your extended care outside of your house of healthcare?
Since you brought it up, I'm just going to put it out here. This is what you're facing with is this person that's in their late 70s. This is actually an income problem is what they're faced with right now, right? Because they got Social Security number 1, Social Security number 2. Do they have any pensions at all?
2 pensions.
2 pensions. We got a pension, and we got another pension, whatever those look, right? I don't even know if the pensions are going up at this point, number 1 and number 2, right? The problem is they're finding out that this is their monthly expenses, right? And they're saying our income sources aren't matching the income expenses. That's an income problem. If they did some planning along the way and guaranteed income, that's a whole nother conversation. Then it's have everything there, right? Let's make sure we have our long-term care plan. Let's make sure we have an affordable Medicare supplement plan. Let's make sure we have our dental plan. Sorry, I'm preaching a little bit about it's an income issue, not having adequately planned in the income category for all these expenses. So I just had to throw that out there. I get on a soapbox, I get going.
Yeah, it's valid.
Very valid. So
except that I just got to throw this in, Mark. A lot of people thought they did plan, but with the cost of living and everything skyrocketing so much, their planning may have been sound, but what things are these days, it's just gotten so out of hand that, these things are happening to people.
And I really think that Gal's frustration was here. They thought we bought long-term care. We got our supplement. We got our prescription plan. We got this, but we're spending 100% of our $108,000 annual income and we don't have much left over. And I think she's frustrated. She's not enjoying the golden years as much as she thought she was.
Yeah.
And I can't help with increasing property taxes. I get that. I got that beef coming in too. The property taxes are just going up, and that's a whole nother beef. Neither here nor there.
Yeah,
but,
it's crazy.
Anyway, with that, I want to invite everybody to our on Mondays. We have our live stream at 9 a.m. Join us for this very thing that you're on right now. We're on Facebook, YouTube, and Instagram here on Talking Turning 65. Afterwards, the next hour at 10 a.m. PST, and this Rhonda would be for you at noon. We have a Zoom office hour where we actually people can come in and ask questions and make it private and it might be brief, but you have the ability to do that. We are going to drop those links down below as well. Special Zoom link. Anybody can come in and ask questions. We don't state everything out here on YouTube and Facebook, but when you come on into a Zoom, we may have some other ideas. You going to join me there, Leith, when that happens? You're going to be with me on that Zoom?
Yep, I'm going to join you. Yep.
That's good stuff. Good, Rhonda. Thanks for joining here today. It's been a pleasure. And everybody's going to know that you're going to see you again. We'll talk more about the long-term care in future episodes, so it'll be fun. So anyway.
Fun stuff.
Yeah, it's fun stuff. Yeah, this live stream stuff is fun, isn't it?
It is fun. It is fun.
All right, everybody. We'll share with a friend and join us every Monday here through the fall. We're going to be on, and we look forward to kicking ideas and questions. Put your questions and comments in the chat. They will pop up for us as well. Join us on the Zoom in the hour following. And with that, we'll see you soon.
Friends, we've reached the end of our 30-minute journey on Talking Turning 65. I hope today's conversation shed light on the challenges and opportunities you face as a rural retiree in the West. See how our Social Security income can be maximized. We know the struggles to create lifetime income. Seek to plan for tax-free income. Build Medicare planning that is affordable. And learn about long-term care planning that doesn't drain the savings accounts when a crisis happens. Have our wills and trusts current, so our family has our desires and not have the state make decisions. If you found value in today's show, please hit like, subscribe to our channel, and share this program with a neighbor or friend. Together, we'll keep the conversation honest and helpful for years to come. Thanks for tuning in, and we'll see you next time on Talking Turning 65.